reform issues. She is married to a dermatologist, Dr. Philip Hughes. They have 3 children. Their oldest daughter is a dermatologist in practice with her father. Please welcome Dr. Jane Hughes.
So when you get ready. Okay, yeah.
Welcome to the jungle. We got fun and games.
Good morning, everyone. It's a real pleasure to be here this morning, and I'm honored to be speaking with you this morning. Every physician in America has experienced the squeeze of third-party intrusions into their daily practice of the art and science of medicine. As an ophthalmologist, one particular day when I realized that I could no longer continue as a preferred provider for any commercial insurance. It was with the arrival of a fax from an insurance company concerning a medication that I had ordered for my patient, whom I'll call Mrs. Jones. I've cared for Mrs. Jones for the past 15 years, having diagnosed her with moderately severe glaucoma. Fortunately, with close monitoring and the innovative panoply of wonderful glaucoma medications we have, her glaucoma has been arrested effectively with topical treatment. Fast forward to the day of the epiphany. I received this CVS Caremark form entitled Brand Penalty Exception Request. Let that sink in. On it, I was to attest that I had tried 2 generic medications that failed to control Mrs. Jones' glaucoma, or my patient would be subjected to the, quote, punitive brand name charge versus the appropriate brand name charge. For those who missed the ophthalmology rotation in medical school, to prove that a glaucoma medication has failed is to show that there has been irretrievable loss of more of the nerve fiber layer of the retina. To knowingly remove a controlled patient from their drug to run a trial of 2 generics is morally and ethically reprehensible. To fill out a form and lie is committing fraud, and it's also embracing the idea that the end justifies the means. This one fax that I received finally laid bare the ruthless, heavy-handed blackmailing of physicians by threatening physical and, financial, as far as I know, they haven't taken a bat to anyone yet, financial punishment of their patients. So as of November 30th of 2015, I divested myself from all PPOs and became an out-of-network physician provider for all commercial insurance. Here is the letter that I sent to all of the commercial plans. And you can read it there for yourself, and I have a copy of it if anyone would like it. More on my stance on Medicare later, and Dr. Woodhams is going to talk about the difference between opted out and disenrolling. But I was already a non-participating provider physician, so those patients were accustomed to paying me for services rendered and being reimbursed from Medicare. And my employees were very comfortable with collecting fees at the time that services were rendered because of this arrangement. This brings me to the purpose of my presentation.
Come with me now. Come with me now. Come with me now. I'm gonna take you down. Come with me now. I'm gonna show you how.
I would like to share my plan for transitioning from third-party dependence on the commercial side and what every single physician in America should consider immediately at minimum for Medicare. Probably the most important step in achieving the will to make this change is to take 1 week to have all of your employees and yourself pay attention to the time spent processing fax and phone requests for generic substitutions, pre-certifications, proof of coverage, denial appeals, etc., etc., etc. I suggest even give yourself and your employees stopwatches. During this week, have your office manager pull the payment amounts for several selected procedures and office visits from all commercial insurance in which you participate, as well as Medicare. Compare the payments. You may be very surprised. I found several of the major insurance companies were paying 80% of the Medicare rate for certain procedures. My office personnel had not noted this downward trend, as many payments come in bulk. There's a variation in patient co-pays and deductibles, and reconciliation does not display the previous payment rate. Well, when I shared what I found with my anesthesiologist, he investigated his practice and discovered that Humana was paying less Medicare for a very common procedure, and none of his billing people had caught the decrease either. So I had a situation where the demand on my time for insurance issues was increasing. The intrusion into the practice of ophthalmology was best described as coercion to falsify information or have my patients be financially penalized, and I was being paid less than Medicare in many instances. With this added information, my resolve was set in stone. It was definitely time for a change.
I read the rules before I broke them. I broke the chains before they choked me out. And I paid close attention, really learned the code. I learned to read the map before I hit the road. Say, nobody's gonna see me coming. Nobody's gonna hear a sound. No matter how they try it, no stopping me since I found my inner ninja. My inner ninja.
No change like this can be undertaken without careful planning, which includes your employees, your patients, and you. Getting your employees on board and enthusiastic is of utmost importance. The good news is that they despise the hassles as much as you do. The bad news is that all change is stressful, and their concerns about job security and the solvency of the practice cannot be ignored.
Wish we could turn back time to the good old days when the mama sang us to sleep, but now we're stressed out.
Involve them in the planning and in the transition. Point out what insurance has done to your practice, to their workday, and to the ability to offer your patients individually crafted care. They need to be very comfortable with cash transactions, discussing fees, helping people make financial arrangements if necessary, and how to explain the new policies. All employees with any patient contact were involved in the transition. I actually made a template of the way that I wanted our policy to be presented on the phone and in person. We actually had practice sessions. Once we made our transition, I solicited feedback on how our patients were responding, and we changed things as we needed to. Now, as the boss, your most difficult job is to create a cash fee schedule. And actually, this is more difficult than it seems at first, because the non-Medicare payments are not what you've actually been paid, but rather a percentage of that. I looked at my non-Medicare fees and my non-participating provider Medicare fees for my most common procedures and services. Next, I looked at the physician's fee reference by Wasserman Medical Publishers for the 50th and the 75th percentile fees for the codes I use, and then this was an excellent exercise for me. I spent a good amount of time determining what was fair and sustainable as a fee for every service that I rendered, and I based it on time required, complexity, usual and customary fees, and resources utilized. The result was my personalized transparent fee schedule, which I posted on my website, and I included it in the letter I sent to every single one of my patients 2 months prior to instituting this transition. This brings me to patient involvement.
Easier said than done. Goodbye.
You will, oh, I'm sorry, I won't want too many here. Oh, I think we're gonna have to listen. This brings me to the patient involvement. You will lose patients, but take heart. They will be replaced. But how you notify them and how you handle the transition will determine how many. No one likes a financial surprise, and I think it's imperative to inform your patients before they arrive the day of the visit. I sent a letter to all of my patients, as I mentioned, and in my letter, I did include my experience with Mrs. Jones as part of the reason for my decision. And as always, my staff and I are careful to say that we are an out-of-network practice for all commercial insurance, being very careful never to say we don't take insurance. Share with your patients that you recognize that they or their employer have paid for their insurance and that you will help them recover out-of-network reimbursement. I do this by filing all claims for the patients with any reimbursements going to them, which is usually about 50 to 60%. This has not increased my overhead since I was filing prior to the change, and I don't want to let the insurance companies off the hook. Many patients will find that there is only a small increase in their out-of-pocket expense to see me when they consider their copay and their high deductible when they use their insurance. We do also offer payment plans for those in need, and I no longer deal with insurance regarding generics, but rather have these discussions and options with my patients. Now, don't think the insurance companies are going to take this lying down. One thing I wish I had included in my patient letter is a warning that the insurance companies will send a letter to them saying that I am no longer in network, so they cannot see me. Choose another provider. I wouldn't have actually known this was occurring except that I had several savvy patients who realized that they had contracted for out-of-network options. Finally, and this is an important point in terms of your attitude and your employees' attitude, reassure your employees that you are growing the practice under a new structure to promote the attitude that you're building something better, and all growth takes time. Now, regarding Medicare, the passage of the Medicare Access and CHIP Reauthorization Act, MACRA, presents an ominous threat to the solo and small practices, and ultimately to the private practice of medicine, period.
Wake up in the morning, don't know what happened. Oh, something bad. Whoa, something bad.
In my opinion, these are the steps that every physician should consider immediately. First, become a non-participating provider at minimum. The next opportunity to do this is November and December of this year. This means the patient pays you at the time of the visit, you file as usual, and Medicare reimburses the patient. This has several advantages, one of which is that you are paid at a slightly higher rate than accepting assignment. Now, everyone needs to understand about participating and non-participating as a Medicare provider, and everything you need to know is on this slide from the CMS website. I will explain it, but as you can see, we have all adjusted to a very convoluted system, and most of us without even understanding it. As you know, a participating provider can charge anything they want for a service, but Medicare only pays 80% of Medicare's determined fee for that service, and the secondary only picks up the 20% remaining between Medicare's decided fee and the 80% that they pay. The physician bills for the patient and is paid directly from Medicare and the secondary. The remaining balance from what that physician charged and what Medicare paid is written off by the physician. Now, there's two numbers there for the non-participating provider. As a non-participating provider, there is a limiting charge, and that amount is the only amount that you can charge for that given service. The patient pays that amount, which is the bottom amount on this slide, at the time of the visit. You file with Medicare, and the patient receives reimbursement from Medicare and their secondary in that middle amount shown. Now, as you can see, the actual limiting charge translates to 9.25% more than the payment that was given to the participating provider Medicare physician. The difference in this payment is covered by the patient when they pay you the limiting charge amount at the time of the visit. That is their out-of-pocket expense. Remember that 9.25%. This arrangement restores the concept that your contract is with the patient for care and their contract is with Medicare for reimbursement for promised benefits. You will have the option to accept assignment on a case-by-case basis as needed, and you will find that the patients become much better stewards of their healthcare dollars, even though they are going to be reimbursed, and you will too, because the questions will shift from does Medicare pay for it to include how much does it cost, why do we need it, and will you tell me ahead if extra testing is necessary. And finally, it sets you in a much better position to opt out or disenroll in Medicare when that time arrives, and without substantial reform, that time will arrive.
No, no, no. My name is no. My sign is no. My number is no. You need to let it go. You need to let it go. Need to let it go.
Second, for as long as possible, do not comply with any of the financially rewarded mandates. The EMR meaningful use, the PQRS, the electronic medical record, the electronic prescriptions. Take the fines, which result in less financial loss than compliance. As you could see from that CMS slide, by becoming a non-participating provider, you will increase your Medicare payments by 9.25%, enough to offset even the 2019 MACRA fines. Your bottom line, your mental health, and your practice enjoyment will instantly improve. A recent study from the Department of Healthcare Policy at Weill Cornell Medical College in New York City, as cited in Medscape in March of 2016, found that the average cost of quality and computer compliance reporting and usage per physicians was $40,000 per year. The authors estimate this translates to hundreds of millions of dollars in annual spending by physicians. One can only imagine the concomitant bureaucratic expense of tracking all that physician data. And this is even before the MACRA escalates demands for reporting and alternative practice patterns and links them to bonus payments. Any physician who takes these bonus payments is at market increased risk for audit and recoupment payments, as is already occurring for meaningful use 1 and 2 of the mandated electronic medical record. Also, when the payment goes to the patient, it will be very difficult for CMS to take money from future billing to solve their discrepancy if they feel like you have overbilled. I was part of a task force that read 962 pages of the CMS MACRA rules and Carl did the yeoman's work. She read all of them. I got off easy. I only had 100 that I was supposed to read and critique. And by unanimous opinion of those of us on that council, no practice will be able to comply, and attempts to do so will lead to financial and professional ruination. Interconnected EMR, connected to CMS as required by MACRA for good ratings and bonus payments, marks the end of our privileged communication between the patient and the physician and strips patients of privacy and dignity. And this is all done under the guise of mega data collecting and eventual best practice rubrics for population health to keep people healthy. Well, maybe the government should be eavesdropping in the priest's confessional so we can stamp out sin, and maybe in the lawyer's chamber so we can eliminate crime. Finally, when the fee reduction for non-compliance becomes unsustainable or compliance becomes mandatory, period, you will be in a much better position to exit Medicare. Prior to that, be proud of your 0 rating by CMS, become a medical Gandhi, and share why with your patients. Peaceable resistance. The decision to continue in any capacity at all in the Medicare program is a very personal one based on many factors. For me, I am a dissident in that I do not comply with the PQRS, EMR, ERX, but rather I take the fine. This satisfies my need to remove myself from the ridiculous mandates, not to mention saving me thousands of dollars per year. This has also allowed my team and me to focus our time and energy on our patients. My patients pay me, and I have never taken a Medicare reward, making me much less of a target for recoupment or audit. One fact people often forget, and actually this weighs very heavily on me, Medicare patients did not choose Medicare.
That's the sound of the men working on the chain gang. That's the sound of the men working on the chain gang.
Medicare patients are conscripts in the Medicare Insurance Brigade, and they are treated as such in the MACRA law, which actually treats them as little widgets. They have had money removed from many years of wages with the promise of health benefits at the age of 65. Now, in a rare act of true government genius, the average life expectancy in 1963, when Medicare was passed, was 69 years of age. The government has betrayed them, and now many of them are paying as much per month for their Medicare insurance, which the government calls a benefit, as they were for their private insurance prior to Medicare. Therefore, as long as I am able to offer state-of-the-art care to my patients, protect their privacy and the sanctity of our therapeutic relationship, and remain financially solvent, I have made the decision to continue as a non-participating provider so that my patients can get reimbursement from Medicare. For example, I am able to offer state-of-the-art cataract surgery with access to every intraocular lens on the market by balance billing, which was legalized by Congress, to afford patients access to this newer implant technology. This allows even modest income patients to enjoy these advanced lenses with modest out-of-pocket charge, while Medicare pays for the procedure and the baseline lens charge. I make less per case than an opted out or a disenrolled physician, but many patients are not in a position not to use their Medicare. In closing, rather than listening to the hype and hysteria coming from people and many of our own medical and surgical organizations trying to sell you compliance tools for MACRA, meaningful use, PQRS, etc., or insurance companies hammering you with untenable choices and threats, start today to channel your energies into taking the steps necessary to transition into an ultimate freedom from all third-party intrusions. I will gladly share my patient letters, my insurance letters with anyone that's interested, and I hope that this starts you on the road to a more fulfilling and a less stressful practice environment. In the meantime, it is imperative that we continue our unrelenting efforts to get insurance and the government out of the practice of medicine by offering patient-centered, physician-guided, free market solutions for reform that must include choice for our Medicare patients as well.
I've tried to cut these corners, try to take the easy way. I kept on falling short of something. I could have gave up then, but then again I couldn't have, 'cause I've traveled all this way with something.
Just one point of further information. A non-participating physician may or may not be able to charge more than a participating physician. It depends on what state you live in. There are some states that in addition to the federal limiting charge law, there is a state limiting charge law. In those states, such as New York State, they ensure that you can only collect less than participating physicians if you're a non-participating physician. So just that little point of additional information. The other thought I had was, in cases where insurance companies are providing false information and sending letters with false information to patients that they cannot see out-of-network physicians, I think that complaints should be filed with the state insurance commissioner. And if you can get your patients to do that as well, I think that would be great. And they certainly should not be telling patients who have out-of-network coverage in their specific plan, that they cannot see out-of-network physicians. So, thank you, Dr. Hughes. Our next speaker is Dr. Trevor Woodhams. He founded the Laser and Lens Implant Center in 1983. He performs thousands of LASIK and intralaser procedures each year, as well as other vision correction procedures such as Vision, implantable contact lenses, and PRELEX, or presbyopic lens exchange. Dr. Woodhams is a former associate clinical professor of ophthalmology at Emory University, certified by the National Board of Medical Examiners, and he is a fellow in the American Society of Cataract and Refractive Surgery. He participated in the world's first LASIK study in Bogota, Colombia. He was the first in Georgia to perform intralase, LASIK blade-free laser vision correction procedure, the Crystalens implant for treatment of presbyopia, the first to perform the Vision implant contact lens and corneal inlays for presbyopia. He has been actively involved in various clinical research projects and monitored clinical studies. Please welcome Dr. Trevor Woodhams.
Well, thank you. Let's see if we can get slides up here. And it was working just a few minutes ago. Well, while we're, got it, okay. Got it, very good. Let's see here. I got to see what I'm saying here too. Gosh, and we had it too. Try it again. Well, this is embarrassing, isn't it? And when we had it too. Do we have it?
Yep. Yep.
There.
And then slideshows. I don't think it wants me to do the slideshow. No, that's not it. I think we've got it now. Here we go. Okay. Technical difficulties. Well, thank you for having me here. I've only been a member of the AAPS for a couple of years, but I certainly enjoyed the experience and to meet people who have similar philosophies of government intrusion. So I was invited, I think, because I'm supposed to be the pioneer that's gone out into the jungle and risk the attacks of the government for not being in Medicare, and I really don't feel that way at all. It's been actually a very easy experience for me. I'm putting this up as an anti-competitive. This is required in ophthalmology because telling other ophthalmologists that they might want to drop out of Medicare could be considered collusion, price fixing, which is odd to me considering Medicare is the one that does all the price fixing and we merely respond to it. Financial disclosures, I used to have extensive work with companies in clinical trials. I no longer do any of that anymore, and that's another story too that I could talk about. So it's really about my personal experience with how I got to the point of disenrolling from Medicare. So what happens if you do it? Well, let me tell you a little bit about myself here. I'm a general ophthalmologist, board certified. I'm not subject to this ridiculous time-limited stuff. I was a clinical professor at Emory for about 20 years, and I've been in private practice since 1982. I am completely out of network, as Dr. Hughes was saying, and have been for about 2 years. And I voluntarily disenrolled from Medicare, which took place January 1st of this past year. Well, it's really very easy. I have a small group. There are 2 MDs that are surgeons, 2 ODs, one of whom is my daughter, who was accepted at medical school and chose not to go. They are participating. My partner is non-participating. I'll explain these things in a minute. I'm also the owner of an ASC, which is adjacent, and employ the optometrists. So why did I leave Medicare? Well, I think the SGR fix was a sham. Suicide by Macker, which has been referred to. I think what we got is going to be far less than what we would have had by the shock of not quote-unquote fixing SGR, EMR, meaningful use requirements, HIPAA, RAC bounty hunters, safe harbor restrictions, and it keeps going, red flag violations, and primarily the progressive erosion of professional autonomy, which has been talked about by several speakers. So why is this no fun anymore? Why was it getting that way? Unrelenting fee cuts, meaningful use divorced from reality. I shouldn't be asking people if they have a gun in their house. QA imposed by outsiders with little, if any, clinical experience, and often in violation of patient privacy. Narrow panels playing doctors off against one another, and the ICD-10 coding requirements, which went up to, 27,000 codes, which I still can't find describing half of my patients. The EMR is really designed, as has been talked about, to mine data and can and will be used against us. And it does not protect your patient's PHI from payers because of their exemption through what is called quality assessment. Internet data transmission is inherently a HIPAA violation. There is no way to secure security, as we saw in the papers this morning and over the past number of years, which I listed in. This is my third weekend traveling around the country, and this is a smaller version, but I spoke about how security issues are such that there is no way you can do anything electronically that is private. So my private practice had become a government clinic, but they didn't have to manage it, and they didn't have to deal with the overhead. So drop Medicare and insurance, people said. I've literally seen people's jaws drop when I've said that in ophthalmology. But in order to do this, I think we need to understand what your options are. Now, I have spoken to many ophthalmology groups, and I'm constantly appalled that nobody really understands what their options are. They're either in Medicare or they're in some amorphous thing called opted out, which I call getting out, because there is a difference, which I will talk about. So there is participation, which is what most people do. There is non-participation, which Dr. Hughes has explained. There is absolutely no reason that every doctor in the care program should not be non-par rather than par. And there is opt-out in quotes. I always put it in quotes because that's the Medicare CMS version of what people would in conversation call opting out, but which is not the same thing as getting out of Medicare. And there is disenrollment, which we have Jane Orient to thank for. So what is participating? PAR for short. Medicare fee schedule amount. It does vary by state to state. You do get at least full compensation for what they tell you. Medicare pays 80%, as you know, after the deductible is met. The check is sent to the doctor with an explanation of benefits. For that 80%, the secondary insurance is then filed through electronic submission of claims. Now, 95% of the people in my specialty are participating, which is amazing to me. And they are, as the title of my last talk to the New Jersey Association of Ophthalmologists, addicts. They are addicted to it. They think they cannot live without it. Non-participating has every advantage over being a participating doctor. But notice the clever use of language, which was no accident. Someone calls up if your staff is not ready. Dr. Woodhams or Dr. whoever is non-participating. It sounds like you're not dealing with medicine. You don't take Medicare patients. There's a maximum limiting charge, as Dr. Hughes has talked about. It is fixed. I thought it was 5%. It's what, 9% now? 9.25% now. It's still fixing prices, though. It's not freedom. But there is a lesser amount that is actually sent to the patient, which I don't think you mentioned in that. But it does figure out actually to come out ahead for doing it. But here's the real kicker about it, is that you can collect the full amount at the time of service, thus restoring that transactional nature of being a doctor and a patient. And maybe even more important is that on a case-by-case basis, you can choose whether to be participating or not. So you are sacrificing nothing whatsoever, even if you live in the most poor and remote area, by going from par to non-par. And then there is the air quotes opted out, or what CMS calls opted out. And it does not mean getting out of Medicare. They're very good with words. It still requires annual, I think it's every 2 years now, and they're talking about taking it to every 4 years, re-enrollment in the Medicare program itself. You can charge and collect what you deem fair, which is a significant change, but you have to sign a contract promising that you will not seek reimbursement from CMS yourself as a doctor. Well, there's no problem with that. Here's where the problem arises. The patient has to sign a contract at every visit that he or she will not seek reimbursement for each visit and service, no matter if it's a Medicare-covered service. I have a problem with that. In order to become opt-out, there are affidavits to Medicare. You have to send a registered letter to all your patients saying that you're doing this. So opting out is not the same as leaving Medicare, which is not the same as disenrolling. So we have to know what we're talking about. So let's talk about this fourth option of disenrollment, which Jane Orient has written about brilliantly in her paper, and which I have sent to at least hundreds of people. You're no longer agreeing to play by CMS rules. And it completely removes this private contract issue that we were talking about. And there's no annual or biannual obligation to renew your agreement. And it does open the door to the possibility of the patient seeking reimbursement for covered procedures. Medicare Form 855I permits disenrollment. I don't think there's any argument there. CMS, however, claims that opting out is private contracting and that there's no alternative to that. And this is what the American Academy of Ophthalmology and the ASCRS tells its members too, which I am in great disagreement with. The attorneys say that this is because of the mandatory submission law, which means you have to enroll. CMS Form 490S is clearly described on the Social Security website to be submitted by a patient directly to Medicare in case the doctor is not enrolled in the Medicare program. Here it is, not enrolled in Medicare. I mean, it's very straightforward. Now, this is not how CMS interprets it. They interpret it to mean if you are treated by a doctor who's not enrolled because you were treated in Canada, or perhaps he wasn't a doctor, he was a physical therapist. That's how CMS chooses to interpret this. So why did I disenroll rather than opt out? Well, opting out only allows the possibility of a change at the end of a calendar year, or the way it is currently every 2 years. So if you change your mind for whatever reason, you're kind of stuck. But mainly it was because, to me, opting out imposes unfair, possibly illegal, and definitely unacceptable conditions for both doctor and patient. How can I be ethically compelled to become an agent of CMS to deny services or payment for services to patients who have had absolutely no choice in putting money or allowing money to be withheld in order to have gainful employment? Patients were promised the ability, the right to choose their doctor, and I have a slide of that with LBJ signing it. But like so many things, it has been amended out of existence or out of recognition. CMS, however, never envisioned that a doctor would not want to be part of having access to that money. So, reimbursement amount sent to the patient is exactly the same amount as would have been sent to me as the doctor. They claim that for budgetary reasons, that can't be. It's ridiculous. CMS and the taxpayer is not one penny poorer whether that money goes to me or whether that money goes to the patient. Now, we know that Medicare is almost out of money. So I am not arguing that CMS should send me more money than they are for something. You send what you can afford to do. I understand that. Just send the same amount to the patient. The patient can also face the choice, as many of my patients do, between seeing the doctor of their choice or the doctor they've been going to for many, many years, or getting reimbursed something at least for that money, all that money that they've been paying into the program during their working years. So, disenrollment or non-enrollment? Well, as I say, CMS denies that it's the legitimate status, and although I have heard of and seen one threatening letter sent to a doctor who did this, it is extraordinarily rare. I've never seen more than one. According to the California Medical Association, who reviewed this, it is not a well-defined option under current law, and it will need litigation to establish its validity. So, does it mean you can't get out? The Center for Medicaid and Medicare Services, CMS, does have a private contracting guideline, and it's very punitive and very threatening, as these things tend to be. And yet many people, understandably perhaps, have chosen to opt out rather than disenroll. But the de facto result of that is that the patient has to surrender his Medicare reimbursement for a covered service. The other implied fact is that any non-Medicare enrolled doctor is now a de facto conscript of the Medicare program, unless they treat Medicare patients for free. I don't think so. Can you survive in ophthalmology without Medicare and insurance? Well, traditionally, Medicare pays for a lot of the patients that we've seen. We have cataract, glaucoma, involutional lid problems, macular problems, which are problems of aging. what can be done in cash in ophthalmology, cosmetic procedures, annual eye exams, optical wear, LASIK, which I have been involved with and perhaps has been a saving grace. But even cataract surgery is now becoming a refractive procedure. As you can see on the picture, this is one of the new lens implants that Dr. Hughes was referring to, in that it not only gets rid of the cataract, but it gets rid of nearsightedness, presbyopia, and astigmatism at the same time, and is not covered by the Medicare payment, which nevertheless they allow you to charge to patients, which is maybe that wedge that we've been talking about. So with the increasingly higher deductibles that everybody is having to deal with, we're already in the cash business. So I looked at this very carefully. I wanted to see what my revenues were. This is a 10-year difference between Medicare, third-party insurance, and cash. You can see tremendous differences, of course. These are questions that people ask me, well, what do I tell my patients? Well, really the same thing that we've tried to do all along, which is that we're in a service business and we're glad to make arrangements if this is going to be an issue, but we want to make them in advance. And we're happy to fill out forms and send them in for you, or better yet, give them to you to send in. Because honestly, there is nobody that's not an expert, and we have difficulty doing this ourselves. How can you possibly expect a patient to do it? So what happens if the patient fills this out, or we fill it out for them and they put it into an envelope? Well, like I say, it does help to know their political orientation. There are lots of people that I talk to that say, man, I'd love to see the federal government. You just let me know about it. Other people, whoa, what's this? Interesting. This is a CMS form. We're frozen. There we go. It's,
There should be an option to start from current slide. Last time I did F4 to cycle back through it. Then I think once you went back to PowerPoint, it was okay. What you were to say?
okay, here we go. So this is the response from the government. It says, in order to submit Medicare claims, the provider must enroll in the Medicare program, which is interesting. A letter that the provider refuses to bill Medicare, like I'm going to give them that. This is it. This is a letter that the patient gets from the provider, from the state provider or the state intermediary for the Medicare program. So have I ever been sent a threatening letter from, well, CMS or anybody for that matter, for this? So we've seen, probably 30 or 40 of these 1490S forms that have been sent off. I've never received a thing, not once. So do we tell patients that they can do this? Well, we do, and we did in the beginning, but honestly, I do also tell them that it's going to be denied in all likelihood, and that most of the time we just have gotten to the point of saying that I'm really not accepting Medicare anymore, and that kind of obviates the whole circular rigmarole. At the surgery scheduling, we do say that, well, I don't take surgery, I don't take Medicare for surgery, the ASC by law has to. So the patient is getting some payment. We're going to gladly submit the paperwork on their behalf, and that works out. Now, the entitlement mentality is such that patients are understandably upset about having paid in all that money, and now they can't use it. So oftentimes, we will give them a discount on the cost of the surgery that happens to equal that 80% payment that Medicare would have sent me, which happens to be about $586. So the net amount of money out of their pocket, whether they use their Medicare or not, is the same. So how do patients react to this? Well, some get upset. Some can be given to other doctors in the practice. Some get angry. Most, though, tell me that, or tell my staff that they're resigned to the deterioration of insurance and Medicare, and it's not a surprise to them. So maybe this is what you all want to know, is so what happened to the business when we did this? Am I out on the street corner saying, you know, we'll work for food, and not really at all. My own personal number of surgical procedures fell in cataract and IOLs 42%. That's quite a bit. However, my partner, who is non-par, well, I'm sorry, this is my LASIK business. This allowed me to put more money, advertising, promotion, and time into the LASIK side of the business. It went up 113% accordingly. My partner, who is non-par Medicare, had his IOL, his cataract business, go up 24%. And this is December through this past August. This makes it look more than it is, but our overall revenues for the entire practice actually went up slightly, 1.4%. We did not lose money. Now, what about the truly poor people that come in and may have nothing but Medicare, or sometimes not even that? Well, I'll do their surgery for free, and I do it every week. Usually the vendors will comp the supplies. They'll give us a free IOL. Would I ever re-enroll? Yeah, I would. I think if Obamacare is repealed, if the right to reimbursement by the patient is restored, I think that it would make it into a better system that I could live with. And how might that be achieved? Well, I think that all of the opted out doctors and a few disenrolled doctors, if they allowed their patients to use the 1490S form, had it denied and collected it, it would be a wonderful basis for a class action suit against CMS. I think the best defense is a good offense, and I think this is the thing that we should proceed with. Another thing, it may be a moot point if Senator Tom Price, who some of you may know is an orthopedist, his patient empowerment bill, H.R. 1140, is ever passed into law. In any case, this has been my experience, and thank you for your attention. If anybody wants to get in touch with me, this is how to do it, and I'm happy to talk to you.
Thank you very much, Dr. Williams. Just one point of clarification, sort of by way of update. The MACRA law passed April 16th, 2015, and although that was an absolutely horrible law, it had one good aspect to it, and that is you no longer have to renew your opt-out every 2 years. You do it once and it's permanent. The other thing is you no longer have to have your consigned private contracts and update them every 2 years. We got written confirmation from CMS that you can have them sign it once, and that's the end of the private contracts. So we will take questions from the audience. Simply raise your hand, and Jeremy will bring the microphone to you.
Hi, I was researching the non-par status versus opting out, and from what I could tell on the CMS website, you still have to take into account the PQRS penalties, the meaningful use penalties, when determining what your limiting charge is going to be, which made the math very difficult, and for me, it just made it seem impossible.
Do you want to
Sure.
address that?
What happens in terms of non-par is you're given from CMS the fee schedule, the limiting charge amounts, and it lists, there'll be 3 settings there. If you don't do electronic medical records, if you don't do PQRS, if you don't do the electronic prescriptions. Right now, that translates to a 6% reduction in the allowable charge. At the end of MACRA implementation, it will be up to 9%, and it's a zero-sum game. The people who do all of the hoops, if they can, which we don't think they can, will get a 9% increase in what their allowable charge. The people who don't will get a 9% decrease from the baseline. So it is confusing until you get that price list, and then it shows you what that actual limiting charge is. You don't have to calculate it yourself.
But the 9% that you get kind of
Yeah,
cancels out.
and what I was going to say was the 9 1/4, as Dr. Huntoon mentioned, the patient actually gets paid less than the participating provider physician gets paid, but the balance between that 9 1/4% more that you get is the patient's out-of-pocket expense. So you're getting 9 1/4 more being non-participating than participating, and when you need to be participating for an indigent patient who only has Medicare, you have that option as well.
And that's unless you live in one of the states that
Right.
have the limiting
Right.
charge, state limiting charge laws, in which case you will be paid less.
I have 2 questions. The first question is, my understanding that if you disenroll from Medicare, that your prescriptions are not valid, that you're, as a disenrolled Medicare provider, that the prescriptions that you write, Medicare will not pay for. Is that
You want to know my experience with it?
Yeah, I want to know your
That
experience.
has not been my experience with it. In all fairness, I have to add full disclosure that we sell our most commonly prescribed medications in order to get around all of the rigmarole and the time involved with, and we're able to sell them for less than the copays.
The second question I have is concerning, again, the disenroll option, and this is more of a legal question. If you are, basically providing the healthcare covered service to the patient, and under the understanding that they will then bill Medicare, wouldn't you still then be liable under the False Claims Act and all of the assorted laws and regulations that undergo with Medicare?
Well, I think that you certainly could be, and I think that if the government wanted to bring a claim against any one of us in this room for something, they could and would. So to me, that it's not an issue. But you said, though, just to clarify something, that we do not lead patients to believe they will be reimbursed from Medicare by filing this 1490S form.
No, I
we
meant-
tell them that it's available there, but that it will be turned down.
I'm speaking to the possibility that there becomes, that it becomes legal by way of an act of Congress that the patient can pay you and then be reimbursed by Medicare. In that circumstance, legally, you could be liable for the payment to the patient.
Well, what they would probably do is try to get me on the mandatory submission of Claims Act, but there is good legal argument against that, and that would become the basis for a test case, which I think we need to get into the court system.
Andy, do you have any
Yeah.
comments on that? I mean, because it's the patient that's filing the claim, not the doctor.
That's not my experience. I will say that, yeah, that I am, part of my case is actually payments that were never received by me, but were authorized by me as a physician.
Well, that could be part of it, but if that's the only thing that's going on, I would be very surprised if the government would ask for this. They may add that on as an additional claim, if they're coming after a doctor anyway, but I'd be very surprised if that's all the government had, if they would go.
From my experience, your argument that the patient's involuntarily paid into the system, this system is so broken, from my opinion, that basically they paid a card-carrying member of the Communist Party. I have no obligation to fulfill the promises made to them by traitors and liars.
I have a question for Dr. Woodham. I'm actually in the midst of starting a practice right around the corner from you in Dunwoody with it, so I probably will chase you down to.
Please do.
answer
I'd
questions.
love to talk to you.
But my question at this point is, from what I heard today, I don't see any benefit to being opted out versus disenrolled.
I agree.
Am I missing that? Or
No,
is
no,
that-
that's totally what I think too.
Okay. I just wondered.
I think that the reason that people think that is because our medical societies are telling us this. ASCRS, I'm involved very deeply right now with ASCRS and their government relations committee saying, basically stop telling our members this stuff because it's, at best, it is, at worst, it is arguable, and at best, it's completely non-true.
Thank you.
The opt-out,
One
however,
point-
is
one point
it's a
to-
safe harbor.
Yeah, the
Okay,
opt-out-
if you follow the rules, it's a safe harbor, whereas non-enrollment is in legally uncharted waters. And CMS does take the position that you're required to file claims for those patients, even though you're non-enrolled. That's their position. Hasn't been tested in a court of law yet. So that's kind of the situation right now.
Yeah, I will say that from a legal perspective, the safe harbor opt-out is there is no possibility of CMS having any say whatsoever on what you and the patient do. There is no money that ever comes from CMS. It is a completely separate situation.
Well, except for emergent and urgent situations. Then you're essentially back in the Medicare system for those patients, and you can file claims and get paid from Medicare for emergency and urgent situations only.
Why would you be crazy enough to do that?
David McCaleb, St. Pete, Florida. Thank you for blazing the trails and helping us all. Can you tell us if you had Medicare Advantage contracts and if you are aware of how it would impact a Medicare Advantage contract? Will they routinely kick people out who are non-par?
Yeah.
Is this
Yes.
a question for me? I mean, you say, do you have, if you mean, does one have these available to them in Atlanta? Well, of course.
Absolutely.
Oh, I see. Well, yeah, sure you are. Yeah, exactly. Sure. Right. Yeah, no, that's yeah, because that's part of the whole process is you're not discounting your fees or your work in some way. I mean, that would be a contractual agreement whether there was a Medicare program or not.
And in some cases, at least one case we're aware of, that insurance company retaliated against an opted-out physician and took the physician off all of their other panels because the physician opted out of Medicare.
If you are a non-participating provider, the patient physician, the patient pays you and you file, and if they're in the Medicare Advantage, they don't get reimbursed.
And another thing to add to that is, and I am also completely out of network, so it's the same issue there, but I've actually had the opposite experience with insurance companies is I can't get them to take my name off of the provider lists. So patients will call me up and make an appointment, and then they're unpleasantly surprised when they arrive to find this out. I've written letters, I've gotten an attorney to send a cease and desist, and they still do it. I don't think it's a matter of malevolence so much as just incompetence.
Why don't we take 3 more questions, then I think we have to move on to the next presentation.
I just want to make a comment because I've been participating, non-participating, and now I'm opted out. So I loved seeing the contrast between disenrolled for ophthalmology, and it's 1 year as of October 1st. And I chose to do opted out because of the prescription writing issue. And every state is different on whether or not you can do in-office dispense. And we recently had a battle with Texas Medical Board where they even questioned us giving post-op kits to patients as being illegal and in-office dispense. And we did win and settle. There was not a problem. But we are fighting for in Texas, and this I think is going to be important for everyone, to have in-office dispense, because if you had, theoretically with disenroll, they will disregard any prescriptions we write. So once I lose my ability to write prescriptions, I'm no longer a physician. So, I mean, I am, but I have the patient can't come to me. They need a prescription, they've got to go to someone else. If I have in-office dispense, I can have everything I need. I can be a surgeon, I can do the LASIK, and I sell them their medications at cost. I think getting in-office, and it's different from every state. And you need to know if your state is in-office dispense or not. The second thing with opted out is they sign the opt-out sheet once. I have to sign it, they have to sign it. It's not every time in every service. You have to know the difference between a secondary and a supplement. With a secondary insurance, for example, with an Advantage plan, as an Advantage plan provider, I couldn't see them. Now I can, and if Medicare refuses it, that secondary plan that's their Advantage plan, they can file and they can get reimbursed. So I have some plans where they're Medicare patients, but because I'm opted out, they use their Blue Cross Blue Shield secondary. There's an Aetna TRS teacher retirement plan. They can submit and they get paid, and I'm totally out of the loop. Also, TRICARE will pay 20 on supplements. Remember, there's a difference between a secondary and the supplement. The supplement pays the 20%. If you're opted out, the supplement won't pay. But TRICARE does, and so even if you do a cataract, the patient pays you, you're out of the loop. They can actually file with their TRICARE, and their TRICARE will pay 20% of the cost. So there's many different ways to do this. So I'm private, you know, they sign the thing, they call opted out private contracted. I don't know which way is best. I see advantages to both, but I don't like the idea that later that disenrolled they could come back and not do a prescription or something like that. But if we get in-office dispense, I may switch. I don't know.
Well, you know, I have the advantage because there are 3 other doctors in the practice who have at least some kind of relationship, participating or non-participating. They could easily write the prescriptions for me.
Okay, let's just take 2 more questions, then we do need to move on to the next panel.
I am Melissa Clements. I'm a dermatologist. I opted out the first time in 1993 when the Clinton Omnibus Budget Reconciliation Act passed. And I have lots of comments to make, but I will observe that recently the law has read that patients can file on their supplemental insurance policies. However, since I have not participated at any level in Medicare for decades, those secondary insurance programs do not recognize their patients' claims, and it's an enormous hassle, and the federal government does come after you even if you are opted out. So I would say just because you haven't had the experience of them coming and saying something to you, it does happen, and it's not pleasant. Also, ancillary services such as pathology, which is covered by Medicare, that my patients in the last 9 months, certainly this calendar month, quite universally have been denied pathology payment from Medicare because they don't have any evidence from me that something was done. So that is something that I am having to deal with, preparing the payment, that this is a cash charge that you will have. I am also having increased difficulty daily being able to write prescriptions for compounds that have been common for decades and decades and decades, have been priced out of reach. For instance, 5-fluorouracil. If you write a prescription for Carac without giving them the magic pharmacy card, it's $2,996 for 30 grams, and that's insane. So I have a tiny office. I can't compound, but I do have relationships with physicians, or with pharmacies across the state that for the moment are able to provide Medicare eligible patients with things that I need to use daily in my practice. It changes all the time.
Okay, why don't we take Dr. Eskew over there as the final question, and then we'll move on.
May I make just one very brief statement? With respect to maybe them coming after me at some point, it's very good and useful to have broad regulatory protection policies. And we have one. MagCell is a very, very inexpensive one.
My question is for Dr. Woodhams. I'm guessing that you want to set some legal precedent, and that's part of your goal here. And if that's the case, when you've educated your patients about Form 1490S, and then they come back and they say, well, the government wants a statement from you saying that you're, disenrolled from Medicare, why not go ahead and give them that statement and let that attempt at precedent go forward?
Well, I may not like, approve of, or be willing to cooperate with the federal government, but I also don't think I should wave a red cape in front of them either. This is not my battle. It's the battle between the patient and the government.
Go ahead.
Hi, I'm Mary Helen Morrow. I'm from Texas. I have been opted out for 6 years now. The difference with opted out in a primary care setting, disenrollment is not an option. It is absolutely an option. You have to be able to write prescriptions. You have to be able, and that covers x-rays you might want to order, referrals to specialists that you might want to order, the whole myriad of things. And what I can tell my patients, my Medicare patients, is you come to me and the only thing not covered is our visit. Everything else I can prescribe or order for DME, anything is covered by Medicare because I'm opted out. If I was disenrolled, none of it would be covered. And that's the problem with Obamacare when they were expanding Medicaid. If you didn't enroll in Obamacare, nothing you did was covered. So they'd see the doctor they wanted to see, then go to the pharmacy and not be able to fill their prescriptions. So yes, I agree, it probably needs to be taken to the courts, but I can't imagine any one of us wants to hang ourselves in the process.
Would you have any problem with telling patients, or any of you opted out doctors, letting them file a 1490S form and get it rejected and collecting it as part of a movement?
Right. They can't do that.
Well,
they can't do that. No.
Yeah, but if they do.
If they do, it's a red flag and they come after the doctor. Thank you to both of our panelists. Very interesting discussion today. I'd like all of the panelists for the next section to please come up to the platform. Dr. Keith Smith, Dr. Christopher Peskowski, and Jay Kempton. I think our first speaker is well known to many of you. Dr. Keith Smith is a board-certified anesthesiologist in private practice since 1990. In 1997, he co-founded the Surgery Center of Oklahoma, an outpatient surgery center in Oklahoma City, owned by 40 of the top physicians and surgeons in central Oklahoma. He serves as the medical director, CEO, and managing partner while maintaining an active anesthesia practice. In 2009, he launched a website displaying all-inclusive pricing for various surgical procedures, a move that has gained him and the facility national and even international attention. Many Canadians and uninsured Americans have been treated in his facility, taking advantage of the low and transparent pricing available. Please welcome Dr. Keith Smith.
I think we're going to maybe do this seated from the table. My only reluctance is I don't think they can see us over here. I'll stand here. Well, thank you for giving us the chance to tell our story. I'm going to tell I'm going to tell a different story at the Surgery Center of Oklahoma this morning than I really ever had before any audience. In 1993, I just stopped filing Medicare claims, and I treated Medicare patients free. I didn't opt out. I had read extensively about the experiences of Lois Copeland and Michael Schlitt, members of this organization, and Jane Orient and the folks at AAPS were real heroes to me, and got me thinking that I needed to better identify leverage in my life and in my practice and just simply eliminate it. So I began to see accepting Medicare payment as receiving stolen property. So philosophically, that's where I was. Recognizing the payment I received for a Medicare beneficiary came out of my neighbor's wallet for the benefit of someone across town he likely did not even know or probably even care about. So it was the most liberating thing I'd ever done. And I think the punchline, the reason I'm telling you that, is I really thought I was something then. I stuck out. I mean, my anesthesia partners said, well, you're a lunatic. I mean, why? Yeah, we see your point, but why does this even matter? I mean, if everybody doesn't do what you're doing, why does it even matter? I mean, it's just like, you know, a rainstorm and a fan. I mean, it just didn't even matter. And I thought, you know, I'm reading about free markets and economics, and I'm getting educated, and I'm really starting to get it, and I'm a real free market guy. And it's only now, when I look back, that I realize just how ignorant I was, that I realize how on just the beginning of a real freedom-seeking, liberty-minded journey that I was. It's only now. And as I think about that, I even think, where am I on that journey now? I mean, can I adequately self-examine right now and know where am I on this path? Well, the next step was to abandon the leverage of a hospital practice as an anesthesiologist. And the only way to do that was to have my own facility. Of course, we took no government money at the Surgery Center of Oklahoma from day one. And we've been open almost 20 years now. And we really thought we were real free market badasses. You know, we've stopped taking government money. We're out of network with everybody. And now we own and control our own facility. We're quoting prices over the phone. And there really was that sort of pride that was inescapable of, you know, aren't we something? And we were. I mean, it was truly unique. But at the time, I thought I was perhaps further along in this liberty-seeking journey than I really was. So things are going great. Surgery Center of Oklahoma was an instant success, very, very lucrative in spite of our pricing. We did very, very well, and we decided we've outgrown this place. We're going to build a brand new facility. We did it without any debt. I mean, we were smart. We identified leverage, and weren't we something? You know, we just, well, this is awesome. I mean, does it get any better than this? Total control of our practice, out of network, taking no government money, no debt, and aren't we something? Aren't we the free market warriors? Well, we got nearly destroyed. And this is a story I don't tell about us very often. We built this brand new facility, moved in 2003, and by 2004, Steve Lantier and I were sharpening our pencils, trying to figure out what expenses do we address because we are facing closure. The cartel finally figured out a way to capitalize on the leverage they had against us as out-of-network providers with manipulating deductibles and doubling down and stacking deductibles, making it financially impossible for almost anybody to come through our doors. And so I had a lot of thoughts about our expenses, and what's one of the biggest expenses you see if you have a medical practice or a business is healthcare. So, well, we're paying $20,000 a month to the Darth Vader Blue Cross for our employees' health insurance? Can we just not offer health insurance? And I really thought about it. Thought, well, let's give some portion of that to the employees instead of giving it to Blue Cross and just not offer health insurance. Well, we couldn't be competitive in the marketplace and not offer health insurance to our employees. So I thought, well, I know I'm going to pay $240,000 a year to Blue Cross. Why can't I buy a policy that is, maybe I take $180,000 of risk, and if I don't spend that extra $60,000 giving it to Blue Cross, then I'm the winner. You know, can I get a $180,000 deductible policy for the benefit of my employees? And an insurance friend of mine said, well, that's self-funding. And by the way, you don't have to take $180,000 of risk. I mean, that's just crazy. I mean, that's so high. We had 32 employees at the time. And I self-funded. What does that mean? That means we seceded from the insurance game for the benefit of our employees. And I'm going through this because I think there are folks in the room who don't really understand what self-funding means. That means I fired Blue Cross as an employer. I seceded from their system and I took the risk. We have 41 employees. We've been self-funded since 2004. And I don't know how many millions of dollars I have not paid Blue Cross. When one of our employees needs a procedure, I write a check. Actually, Jay Kempton writes the check for me because I'm busy, and that's what he does, and thank you. So I wanted to go through that because up until that point, you know, weren't we something? Weren't we free market? No, we were feeding the beast. When we were self-funded, we began to understand from the employer perspective, what is the sticker shock of purchasing health care? That ushered me into another place in my kind of liberty journey. I started to think of myself, well, now I'm actually a consumer. I'm seeing it from the consumer side a little bit more clearly. We still almost died. So we self-funded. We took $240,000 we were paying to Blue Cross and instead banked it and used that to pay our employees' health care bills. In the first year, I think our entire spend was $25,000. So we saved almost $200,000, or a little over $200,000 the very first year we did this. So now I'm a consumer in the marketplace. I'm also a physician, with a service for anybody that would come to the Surgery Center of Oklahoma. So I began to see the market from two different sides. And then things got worse. The collusion continued, and we're looking at our expenses when I realized I'm not the only self-funded consumer in the world. My God, there are others who have done this. There are other physicians, there are other facilities that are self-funded. There are businesses that are self-funded that have rejected Blue Cross, United, Cigna, Aetna, Humana, Nazis. So they were buyers in the healthcare system. And I thought, how do I distinguish myself to these people? What do I do? How can they know? How can they know who we are? How can I get people into our waiting room? We were better, quality-wise. We knew we were better than anybody in this town, probably in this region. And I knew we were cheaper. How did we convey that? We put our prices online. We doubled down. We were at that place where we thought we were just these free market badasses, and we just had our toe in the water. We weren't even close. We weren't even close to where we needed to be. And so we doubled down. And I think putting the prices online was, looking back, just another step. There's not a day that goes by that I don't either come up with some insight that makes me more consistent with the market, or I receive an insight from some other person that is part of, this movement or the free market movement sweeping the country. And these insights, I think, are instructive, and we have to all keep our ears open and understand that wherever, and this is like a confession, wherever you are in this journey of liberty seeking, there probably is another thing you're missing. And I would encourage you all to stay open-minded. Had I not, I think, been thumped on the head by members of this organization and others in the buying community that are buying health, I don't think I would have seen it. The beginning of this journey for me was AAPS. So thank you to all of you.
Thank you, Dr. Smith. Our next speaker is Dr. Christopher Peskowski. Oh, okay. So we've had a little change in order here. Mr. J. Kempton is our next speaker. In 1992, he started his journey with the Kempton Group, which was founded in 1969 by his father, Wayne Kempton. He became president and CEO in 2003 and has diligently worked with Oklahoma employers to ensure their employee benefits fit the needs of our community. In 2011, he became aware of the free market medical movement in Oklahoma and what it could mean for health care in the community. Please welcome Mr. J. Kempton.
Good morning, everybody. I really appreciate the invite to talk to you all today. I've been before the AAPS once before. It was, I think, 2 or 3 years ago down in Louisiana. And kind of like Dr. Smith had mentioned, boy, when I was invited to the AAPS, I thought, wow, what an honor. I'm going to be down there. They're going to love me because I am this free market-minded third-party administrator. And when I stood up here and talked, boy, I was getting a lot of daggers out there from the audience. I really did not get the warm reception, and it took me about 20 minutes as I was talking and was starting to get some feedback from the audience. I learned why I was not so well received, and Dr. Smith actually kind of teed this up a little bit for me with his remarks, is that I think a lot of physicians and a lot of folks in the medical community, they do not really understand what self-insurance really is. They understand how self-insurance manifests itself to them, which usually it looks a lot like Blue Cross Blue Shield, United, Cigna, Aetna, Humana, because there's a lot of insurance companies out there that provide administrative services for self-insured employers. Those insurance companies, when they are working on behalf of a self-insured employer, the way that it's presented to you is just like another Blue Cross and Blue Shield member, just like another Blue Cross and Blue Shield policyholder. But that's not really what's happening. In a truly self-funded environment, the employer chooses to sponsor a self-funded health plan. Just as Dr. Smith had mentioned, he said, I'm going to secede from the healthcare mess out there, and I'm just going to take it in-house. But like so many employers that decide to do that, he's busy running a practice, and he needed somebody to assist him with writing those checks and advising him, especially now in the ACA world, trying to keep the plan in compliance the best you can. And so he usually would go out, or an employer in that situation, say, well, I'm self-funded, I'm going to go ahead and hire a third-party administrator to help me run my plan. Well, folks, that's how the Kempton Group operates. We are lucky enough to be the third-party administrator for Dr. Smith, and I absolutely understand that I'm helping him administer his self-funded plan. It's his nickel, it's his risk, and the design of what's covered and what's not covered and how rich or how not rich that benefit plan is determined by the employer. What fits the needs of their employees the best, because correct me if I'm wrong, but you really want happy, healthy employees that show up every day and aren't sick and all that. That interest is usually very much in alignment with the needs and desires of a patient. But if Dr. Smith had chosen Blue Cross and Blue Shield to be his third-party administrator, they really kind of take control of his plan. They dictate to him. He's still on the risk, still his nickel, but they tell him what's covered, what's not covered. They're going to tell him what network to use, what the pricing that'll be dished out to the provider community will be. So even though he is technically self-funded, unless he is with an independent third-party administrator, somebody that works in purely a clerical role, it doesn't look like self-funding. And I think that's where you all were looking at me. I do not take any risk. I do not dip my beak into the claim stream that his employees have. I don't have a stake in how much is paid out to the medical community. That self-insured employer, the way I look at it, and this was kind of the basis for the Free Market Medical Association that Dr. Smith and I founded, was identifying the buyers and sellers in healthcare. And when Dr. Smith and I met back in late 2011, he knew about self-insurance, he knew about self-funded employers, and I said, my employers are just like you. We're just buyers of healthcare goods and services, and my employees, they do business with PPO networks and all the garbage that's out there, all the layers that are in healthcare, but they don't have to. If we could actually find a seller of healthcare goods and services that would be willing to do business in a very open, transparent way, even cash, then we could bring a lot of buyers to your front door. And that's what we did after Dr. Smith and I kind of had our meeting of the minds there, and we didn't negotiate pricing at all. His pricing was already on the website. I said, my gosh, it's a great deal. I think my employers they need to be aware of this. And we simply recommended to our employers that they should modify their benefit plan, that whenever they used free market pricing, and at that time there was only one free market facility that was selling, that was open for business, but we modified those plan documents to say if you use Surgery Center of Oklahoma in their cash pricing, then it'll be a cash transaction. In other words, the benefit plan provisions, the deductibles, the co-insurance, the pre-certification, all that yak, it evaporated because the employer is the one that owns that plan. And they looked to me and I said, yeah, if you buy from this place, the pricing is very fair. In fact, it's better than the pricing that you'll see anywhere else. And so 100% of our clients do business with Surgery Center of Oklahoma on a cash basis. The employer is the one that's making the funds available, but it's not any different to the seller of care than if that patient walked through the door with a briefcase full of $100 bills. I think that's important when you all look in your communities to try to increase, for those of y'all that have a cash practice or are contemplating having a cash practice, if you can find, and the employer is where you need to talk. That's where you start your conversations. If you have a larger employer, say over 100, 150 employees within your community, and you know them socially, talk to them. See if ask them if they're self-insured. If they're self-insured and they're with United Healthcare, you can tell them all the reasons why that's not a good thing for their patients or for you or the community, etc. But if they're self-insured and they do business with somebody like the Kempton Group, a family-owned TPA, and there's still a few of us out there, if the TPA works for their client as an administrative-only service provider like we do, then you ought to be able to talk to your employer in your community and say, hey, let's get a meeting with the TPA because the TPA works for the client. be a great avenue for you all. I'm going to briefly go through, I don't know how much time I've got left, but I'm going to briefly go through some of the pillars of the Free Market Medical Association. Actually, very quickly, I'm going to go through, before I go to the pillars, I'm going to talk about some of the bad news. I think I've told you some of the good news. In our marketplace, there's over 50 facilities like Surgery Center of Oklahoma. Well, none of them are exactly like Surgery Center of Oklahoma, but there are about 50 facilities in this region of the country that have emulated Dr. Smith's model, and it's been based upon just free market competition. Because when we were paying those patients, if they went to Surgery Center of Oklahoma, the care was free. That definitely sent a signal to the marketplace. But we see, I saw it just this week, I saw two things that really raised my eyebrows, and I wanted to share with AAPS so you all can take these back into your sphere of influence. First off, we were talking with a medical provider in Texas that is in rural Texas, and they most recently fired the PPO network that my employer accessed them through, which if I was a normal TPA, I would be telling all those patients, well, you can't go see that clinic anymore because they're out of network. We take the opposite approach. We say, whew, finally, the provider's out of network, now we can go down and talk to them. Now we can talk buyer, seller. Except for this. This is a medical provider, a clinic, pretty good sized clinic. We went out to talk to them about doing some direct contracting, whether they were willing to accept cash or some percentage above Medicare. It's certainly not a top-down deal. It's a conversation. And they said, well, we do some direct agreements out there. I said, well, great. Where are they? What do those agreements look like? And they shared with me. I was like, my gosh, that pricing is pretty high. It's pretty egregious. It's definitely much higher than some of the other free market providers out there in the area. And said, well, we do some direct contracting. I said, well, with employers? And I said, well, yeah, we do a lot of direct contracting, and that's the deal that everybody accepts. As I started to pry a little bit more, their idea of direct contracting was having a direct agreement with an insurance carrier. And I said, well, what I'm talking to you about is working with First State Bank of Broken Bow. And they have 32 employees. I said, well, what's the difference? I said, oh my gosh, what do you mean what's the difference? Having a direct relationship with Blue Cross and Blue Shield is a relationship at all. You should look at possibly, maybe we can waive deductibles. Maybe we can make things where the transaction is smoother, easier for you if you would be willing to talk with the employer. This happened this week. I have not gotten this clinic to see the difference between a self-insured employer and Blue Cross and Blue Shield. I'm going to work on it. The other thing that I heard, which I don't think you all probably, this probably won't be news to you all. I've talked to you about sellers and facilitators. I'm a facilitator. Right now, in the healthcare marketplace, transparency-minded facilitators are coming out of the woodwork. Transparency is a big buzzword out there right now. Be very leery of any facilitator that is trying to bring you patients, that they are not violating any of the pillars of the Free Market Medical Association. Those pillars are out on our website, and I think if you would take the time to read those, it will arm you as a seller to see who is actually wanting to come to you as a buyer and who is wanting to come to you and just act as a ticket scalper. So I would encourage you to go out to fmma.org. We also have the executive director and the membership director of the FMMA are here, Megan and Mindy, and they will hang out a little bit after our remarks. So thank you very much for your time.
Thank you. Our next presenter is Dr. Christopher Pezkowski, who is an ENT surgeon, Surgery Center of Oklahoma. And he received a Bachelor of Science from the University of Oklahoma with academic distinction in zoology, minor in history, and graduated from the University of Oklahoma College of Medicine in 1996. He interned at University of Alabama at Birmingham, Division of General Surgery, and completed residency in otolaryngology in 2001 at the University of Alabama in Birmingham. He's board certified by the American Board of Otolaryngology since 2002 and is a member of the Oklahoma Academy of Otolaryngology as well as AAPS. He was born and raised in Oklahoma City, and he, his wife Marcy, have been married since 1992 and have 2 children, Carson and Morgan. Please welcome Dr. Christopher Pezkowski.
Good morning, thank you much. Thank you, Dr. Smith. I've been a member of AAPS for about 5 years now, and this is my first meeting, so when he said, hey, you want to talk? I'm like, gosh, great, thanks. It's good to have it here in Oklahoma because I only had to drive 15 minutes to get here, which was awesome. But thank you all for coming. I hope you've had a good time in our state. 50% of doctors end up living within 50 miles of their mother-in-law, and so that's how we ended up back in Oklahoma. But it's been great. Training at Birmingham, we had a tremendous surgical experience. I mean, operated our tails off. We quit counting tonsillectomies and tubes after number 1,000. I mean, it was the very busy children's hospital. And I can remember we'd start out, there was 2 rooms, 1 attending surgeon. I'd go into the room, we'd be doing a tube. The nurse would be standing at the door with the next patient, ready to come in the room as soon as the sheets were changed, wiped down, and changed the anesthesia machine. I mean, it was just a machine, and it was unbelievable surgical experience. So I come to Oklahoma, I joined a single specialty group, large group at the time, was about 8 physicians. We've grown to 13 now. Not everyone is a partner at Surgery Center of Oklahoma, most are. There are other ear, nose, and throat doctors at Surgery Center of Oklahoma that are not our partners. That may change in the future as we work on things. But I can remember starting my practice in Norman, and I was the 4th doctor, and an ear, nose, and throat doctor in a town of about 100,000, and it's a process, it's a slow process growing your practice. And so I had partners up in North Oklahoma City at the Mercy Hospital, the Merciless Hospital, as Dr. Smith likes to call it, based in St. Louis. And I had a partner, he's 80 years old, and he's just quit operating, but he's still seeing patients in the office, and he said, hey, if you'll come up here and do clinic 1 day a week, I'll give you all my patients that need surgery. And I was like, great, I need things to do. So I started operating at Mercy Hospital 1 morning a week on Wednesdays, and I would do clinic on Wednesday afternoons on one of my partners who was out golfing in his space, and they didn't charge me rent, and it was a wonderful way to build practice. And then as I got busier, I think it was about July of 2003, I had 8 surgeries on in 1 day at Mercy Hospital. It was 3 tubes, 3 tonsils, a small sinus case, and a direct laryngoscopy, maybe 2 hours worth of work of my operative time. I was there 10 hours, from 7 a.m. till 5 p.m. as I watched anesthesiologists wheel their carts in and out of the room as they took turns in the shift. And I did, when I was young and I didn't know to ask for 2 rooms or anything like that, but I thought there's got to be a better way to get things done. And it wasn't any faster at the Norman Regional Hospital as far as getting stuff done. And so fortunately, one of my partners, Dr. Mark Gilchrist, our current president of our group, was a partner at SCO from the very beginning, or not a partner, he operated there from the very beginning, and he became a partner after a long time because he couldn't prod his nurse into getting patients to go there very well. And so he brought me to the new place that had just opened in spring of '03, and he said, hey, this is much better here, you should come operate here. And I'm like, all right, came met Keith, and started operating, and I could now do those 10 cases, or 8 cases in 2 hours, back, bam, bam, and it's awesome. My stress level is so low because he takes such good care of kids. I do probably half my practice is pediatrics. So at the time, they were out of network for everything, and out of network copays and deductibles were much lower. But it was still a lot of work for my nurse to get patients to go there. And so the best way to get someone to get motivated is to give them a bonus. And so if she could get 10 patients scheduled there, as long as it didn't cost them any more out of pocket to go to the out of network than it would to an in network, because my number 1 goal is it should never cost patients more out of pocket to go wherever I take them than it would be somewhere else. Regardless of how much it would benefit me, it has to be the best for them. And if she could get 20 cases on in a month, she'd get a $200 bonus. So a $100, $200 bonus. And for someone making $10, $12 an hour, I mean, it made her do the extra time. So incentivizing your staff, it will get them motivated to do things. And so at the time, really, Coventry was the only plan that was in network, which, that was the teacher's plan here in Oklahoma. And it was in network. And I don't know how that came about, but it was. So I was able to get some in-network patients there. And then the tribes here in Oklahoma, the Chickasaws specifically, did not have an ear, nose, and throat in Ada. And I had a partner who had come from Ada. And so there was kind of a pipeline of Indian patients who would come to Norman, and then we'd take them to the Surgery Center of Oklahoma. And so things were going pretty well. And then when Keith posted the prices online, and I remember talking to my wife and saying, why will Blue Cross and United not contract with us? Our prices are great. I mean, we're going to save them so much money. I mean, how can this not be a deal? And then as the layers have been peeled back and PPO repricing and learning how Blue Cross makes more money saving the self-funded company's money than they do actually in selling insurance to individuals. And so that was a long process. And so when he posted his prices online, that was wonderful for me. I mean, I've taken out tonsils from folks from Austin, Texas, and North Carolina, and Louisiana, and California, all over the country. And so I joined AAPS, and the journey continues, and I opted out of Medicare 3 years ago. Thank you. Fortunately for ear, nose, and throat, our practice is only about 20% Medicare as a standard across the board. Most Medicare problems in the elderly are hearing loss and tinnitus, non-operative problems. Cancer is very, very rare. I see patients in the hospital when I'm on call that are on Medicare, and I don't charge them. I don't file a fee. I just don't want to be off Medicare's radar. Fortunately, those are a small number. So now, when Governor Fallon was here at the start of the meeting, she mentioned Health Choice, which is now the Oklahoma Teachers and Employees insurance plan and is contracted directly with the Surgery Center, which is just spectacular. It brought to mind, people are going to say, gosh, if you're getting free surgery, if it's going to cost them nothing out of pocket or deductible for them to go get surgery, there's going to be a lot of unnecessary surgery. And the answer is no, there's not, because people don't actually want surgery. I remember when I first started practice, I would see people I'd get a CAT scan of their horrible sinus disease and their horrible polyps, and I would say, you need sinus surgery. You will be so much better if you have sinus surgery. And they just look at me and go, uh-huh, okay, I'll see you later, doc. And they would leave. And I'd tell my nurse, people don't like me. They don't trust me. She said, I don't know. And then 2 or 3 or 4 years later, these people come back. And they're still miserable. And they finally say, okay, doc, we'll do the surgery. So and that's how your practice grows in the ear, nose, and throat world. So people in Health Choice, they don't want their child to have their tonsils out. But if they're having strep 6 times a year and missing school, or if they're snoring, or if they can't hear and they're developmentally delayed because they can't hear, they want their child to have surgery. A lot of these people with a $5,000 deductible, they might not be able to afford it. They would put it off. I mean, ear, nose, and throat is one of the few specialties where we can do surgery on a child and improve their quality of life, their ability to grow, and growth hormone is not produced during dream sleep, and if they're snoring, they don't have dream sleep, and it causes overbites and adenoid facies. There's a reason that people look dumb. As a pediatrician friend told me once, that the face grows at the same time as the brain, and so if you're not breathing through your nose and your brain's not getting oxygen at night, it changes the way your face works, the way your brain works, and so I think it's going to do a lot for quality of life of kids and adults here in Oklahoma, this new option with Health Choice. Thank you very much. I've really enjoyed this meeting. Thank you.
And thank you. We do have lots of time for questions, so please raise your hand and Jeremy will bring the microphone to you.
This is for Mr. Kempton. Does your organization work nationwide?
We have patients in almost every state, but no, our employers that we do business with are based primarily in Oklahoma and Texas. We are not a large company. I have about 45 employees, if that gives you any idea. We're not a big player, but we're a good one.
Two questions. I can't stay to go to the surgical center today. Do you ever have visitors, other physicians come in at other times they call ahead?
Yes, not between now and the end of the year.
No.
But absolutely, with the heads up, I'll mark some time out and buy you lunch.
And the other thing is I had torn a muscle biceps, and I couldn't make it out here to the Surgical Center of Oklahoma because I couldn't have someone come. I only had a 2-week window, but when I showed my friends the price online versus the price at the local hospital, well, not the local hospital, but the medical center hospital, yours was $6,202 or $6,200. Theirs was
$6,260.
Okay, you increase it, but nonetheless, theirs was between $14,000 and $30,000 for the hospital fee, and I said, I'll take 14. They said, no, you can't choose. And I said, well, I don't want to sue you. So, see you. Thank you.
Yeah, come out anytime. Not anytime, not between now and the end of the year.
And if you please stand when you ask your question, please.
Twyla Brave, Citizens Council for Health Freedom. Thank you so much for that lovely presentation. Will you just explain to me, because I do have some people who call our organization and they ask questions about the surgical center and they'll say about Medicare. So just explain to all of us, your relationship with Medicare patients and Medicare.
Well, I stopped taking Medicare money as an anesthesiologist long before we opened the Surgery Center of Oklahoma, and I just treated those patients free. I didn't file claims. I just treated them. And some of them paid me. Most were angry, told me they were not a charity case. But we still see Medicare patients at the Surgery Center of Oklahoma. I just tell them to leave Darth Vader in the car. But the Surgery Center of Oklahoma accepts no federal money. Most of the patients that I see are folks who are managed pretty well with an epidural steroid injection once every year or 2 years that keeps them out of the operating room. And they've experienced the lack of care at other facilities that they didn't care for. And so they would show up, and my website price for an epidural steroid injection for my fee and the facility is $700. In a lot of places it's $3,000 or $4,000. So they'll come in and it's $700, and if they don't have $700, I don't care. I mean, we just do it. And some of them do and some don't. So that's how we treat them. I mean, I shouldn't be here. I mean, all we've done is say, here's what we do and here's how much it is. And then if somebody can't do that, we look them in the eye as our patient, and we work something out. I mean, my great uncle was the only physician in Chickasha, Oklahoma, just southwest of here. This is how he practiced medicine. I mean, this is exactly how he practiced medicine. So this is a real throwback. Two things you all need to know. If you've ever heard me say that a physician cannot be ethically the medical advocate of their patient without also being their financial advocate, that is his quote. That's Chris Paskowski. You cannot claim to be somebody's advocate medically while you participate in their bankruptcy, and that's a part of what we've all embraced. And the other thing y'all need to know about Chris, I think the strongest anti-MOC language in the country is here in Oklahoma legislation, and he got that passed. He did all that. That was you.
That was in Tulsa. That was Dr. Siegler who got that. I came to it late on that, so the Cleveland County Medical Society's president last year, and my mission was MOC against MOC, as I've learned about it and read the Newsweek articles, and so I got a legislation or a referendum from AAPS and sent it into the State Medical Association. They said, well, Tulsa has already submitted this. Would you like to sign on with them? And I'm like, oh, well, yeah, sure. So, and then we were having the state meeting in April when it passed and Governor Fallon signed that law. And so I came late to it, but I was in full support of it. And the OSMA did pass a referendum supporting National Board of Physicians and Surgeons. Our Surgery Center of Oklahoma accepts that explicitly. The Oklahoma Heart Hospital accepts NBPAS certification. I am trying to change Norman Regional Hospital. In Texas Hospital, which is a large hospital here in Oklahoma, accepts it now. They've changed their bylaws to accept NBPAS. There was a question earlier in this week, why is NBPAS only good for 2 years? And that's because it's based on continuing medical education, CME hours. Oklahoma, we have to have 25 hours per year to maintain our license. NBPAS is 30 hours per year, or it's actually 60 hours every 2 years, or 50 hours every 2 years. But if your certification has lapsed, you have to have 100 hours of CME in your specialty in order to get board certified with them. So that's why they want you they want to verify that you've done your CME every 2 years. And I actually had to mail in my certificates to them, whereas here at the state level, a state license, you just check a box attesting that and then you're supposed to hold on to your certificates in case you get audited. I don't know anyone that's ever been audited by the state board for their CME. But that's how why the NBPAS is only 2 years, is to make sure you're doing your CME, because their commitment is to lifelong learning, just not through the maintenance of certification and the onerous ABMS system. So.
I'm Todd Kiefer. I'm just an advocate. Some of you probably know me from Twitter, Free Market Monkey on Twitter, freemarketmonkey.com, my blog. I cannot tell you how lucky, how fortunate I am. I need to tell this story. It just so happens that in my county, in York, Pennsylvania, in 2014, I was aware that a physician-owned orthopedic surgery center had the intentions to emulate Surgery Center of Oklahoma. And I went to the FMMA's second annual meeting last year, and I learned about how this direct contracting with self-funded employers is just really taking off. And I understood the significance of it, and I went back and I got a hold of one of the surgeons from this surgery center, and I went and I looked at their website, and nothing had changed. And I said, and I got a hold of Dr. Panis, and I said, Nick, what's going on? I know you guys want to emulate what Surgery Center of Oklahoma is doing, but nothing's changed. I don't see cash prices. I don't see anything different. And he got back to me and he said, well, we're having trouble figuring out how to set our pricing and so forth. Maybe we could get together and talk about this. And I said, absolutely not. I am not who you need to talk to. You need to talk to Dr. Keith Smith. So I connected the two by email, and a couple of months went by, and the communication started going back and forth, and then plans started being laid. The third Wednesday of May of this year, OSS have posted their cash prices online. Since that time, they have gotten an independent urology practice and an independent gastrointestinal practice to go in on this. We have a meeting scheduled October the 14th in Harrisburg, Pennsylvania, to roll out the opportunity to self-funded employers in our area, this opportunity to direct contract with these fine facilities. So, and I must mention, these guys, and it's going to be done right, because these guys were so gracious in mentoring our local people and helping them get this thing going. I just know we're going to be successful.
I'm Ken Christman. I'm a plastic surgeon in Dayton, Ohio. And I've had unbounded admiration for Keith Smith for a long, long time. What he's done is amazing, and it should be replicated all over the country. Unfortunately, I don't think it can be because of the intense hatred that the nonprofits have for institutions like his. It's horrible, but they are doing physicians so much harm because they will not allow institutions in most places around the country like Keith's to survive. And they have a lot of political clout and they have a lot of capital. I'm also a huge advocate of cutting out the insurance companies. But let me just ask you a question, Mr. Kempton. Is what you're doing through the ERISA law, is this federal law with the third-party administrators and the self-funded groups?
Yes.
Okay. I would just suggest this as a caution to some. In my situation, it may be unique, but I've done extensive maxillofacial trauma for 35 years. And a few years ago, I had the absolute worst case that I've ever seen in my life. And I doubt that this kid, I know he should have died by all standards. Just about every bone in his face was crushed. And I've never seen anybody with this kind of injury survive. And his mother actually worked for a hospital in another state, and he was helicoptered into where I was. And the ERISA law was something that the self-funded hospital hid behind because they felt that they could do whatever they wanted to. And they called his treatment, which was multiple surgeries, probably 20, 22, 24, something like that. It was expensive, okay? There was a lot of work done. This guy almost died. And it was all experimental because they didn't want to pay for it. They wanted to get him out of the hospital as soon as they possibly. This is another hospital. This was another hospital where he was at because the somewhat rural hospital in the other state just didn't want to pay for it all. So they called it experimental, and then they hid behind ERISA law. And then we ultimately had to file a lawsuit against them because they were just refusing to pay. They were just looking for any reason to refuse to pay.
When you said a hospital was doing this?
This was the hospital that the patient's mother worked at. Okay, so they had a self-funded program, and through their third-party administrators and everyone else, they were hiding behind ERISA law, which makes it very, very difficult to take them to court. And so what I'm suggesting is that instead of this being under ERISA law, all other insurance is all under state law. And so under state law, the Department of Insurance then has jurisdiction over these insurance companies, and at least they can do something about it. But under federal law, they ignore it. As a matter of fact, so much so that this self-funded hospital, through its attorneys, actually threatened me and saying that if I did not win this case, that they would come after me personally. And they mean it. You know, they're very, very aggressive because the federal law allows them to get away with all of this. So what I'm suggesting is the federal government, when anything gets involved in the federal government, you know, they make a mess of things. Look at what our Medicare situation is like. With other insurance companies, you either participate or you don't. But with Medicare, what do you have? You have non-participating, you have opted out, you have disenrolled, you have a whole system out there that is just crazy. And so what I would suggest is that all of this ought to be, you know, we can't accept Medicare and what they're doing and how they're defining all of this. We also can't accept, in my opinion, you know, the federal law getting involved in insurance in a situation like this, and maybe it all ought to be under state law, and I don't know how you would feel about that.
I'll definitely comment on that because we hear that a lot. It sounds like to me you had a bad actor. That hospital was a bad actor, and they did stand behind ERISA. ERISA is not a bad law. In fact, ERISA is probably the best consumer protection, patient protection law that has ever existed. Because, you know, ERISA, the main standards behind ERISA is that plan assets are used for the exclusive benefit of the beneficiaries. Can't be, I can't take that money and go buy a vacation home with it. Dr. Smith can't do that either as a self-funded plan sponsor. But this is where I think this bad actor was hiding behind ERISA. Is there's another provision within ERISA that states that the funds of a self-funded plan can only be used for reasonable expenses and to defray reasonable administrative expenses. And again, bad actors, whether they be employers, in this situation it was an employer, just happened to be a hospital, it sounds like, did use ERISA to actually reduce, it sounds like, the benefits available to that beneficiary. I don't have any employers that operate like that, and if I did, they probably wouldn't be one of my customers for very long. And you know, Dr. Smith, if he had if there was an employer that played those kind of games, he'd just say, you know, I don't sell to you anymore.
Isn't that why you buy reinsurance?
That is why you buy reinsurance, yeah. But I hate it when you know, bad actions get blamed. So, oh, well, ERISA enabled that. Well, I think it's a misapplication of ERISA that enabled that.
Michael Robb, otoneurology, Phoenix, Arizona. Question regarding off-label surgical interventions. May we refer patients to you for cochlear implant, vagal nerve stimulator, and other same-day surgery procedures that would be considered off-label for suppression of tinnitus, for example? And could you get a discount on the cochlear implant device, as well as offering them a great professional fee and facility fee, and then we would follow them up in a different state?
Yeah, we have I don't do cochlear implants. We have otologists, 3 or 4 that do cochlear implants. As far as I know, it's about $30,000, and that includes the cost of the implant, or it's $6,000 plus the implant, and
It's $8,500 plus the cost of the implant, which varies because the companies. It's $8,500 plus the cost of the implant, which I don't include in our price because the companies that make those are warring. You know, it's nice to pit them against each other, and then you wind up with a better price. So. Yes, if you want to refer someone in order to spare them bankruptcy to benefit from our pricing and are willing to follow them up locally following implantation of cochlear implant or whatever, we would be thrilled to be in a relationship and an arrangement like that with you. What I would prefer is that you approach a facility where you're comfortable working and see, if you don't match this, they're going to Oklahoma City. And then we help you with that, because that makes more sense.
Absolutely.
Hi, Michael Reesberg, ENT, Pensacola, Florida. A question for Dr. Smith. I know one of the advantages, besides efficiency that was just mentioned in outpatient surgical facilities, is that reimbursement tends to value the physician and the surgeon and anesthesiologist more for the value of his time. How do you normally do that? I know much of it is a cash basis. I've unfortunately never been privy to being able to work in a facility where they do have transparency in the pricing. Since it's not reimbursed from insurance, do you normally have an agreed upon fee schedule among the surgeons or the physicians, or is it purely a dividend for the owners as their benefit from doing surgery there?
Well, it's both. I think you're asking two questions. How are the profits distributed from our facility, but also how did we come up with our bundled pricing? Who gets what? Is that? So I love this question. So to determine how much Chris Paskowski should be paid by a patient for a tonsillectomy, I determined a radical course to get that answer. I asked him, how much do you want? What is your time worth? And I think we did this with 4 or 5 guys in the room. I took a select group of our surgeons, and how much do you want? And I mean, Chris is smart, but a lot of the guys didn't know. They had no idea. And my response then, well, you're either tired of somebody else telling you what you're worth or you're not. You know, you need to give me the number. I don't want to be the central planner. I don't want to impose it on you. You tell me what it is. And in every single case, the prices were way too low. What I was hearing was shocking, frankly. So I think without exception, every single price that a surgeon told me was acceptable, that would feel like a mutually beneficial exchange, I padded. So in control and owning our facility, we've taken the institutional charge, which is where most of the bankruptcy comes from in healthcare, and we did this. So we took the institutional charge that traditionally had generated real profits for the Surgery Center of Oklahoma, and we did this. We just ratcheted it down. We have a marginal profit, but it's not large. It's a base hit, not a grand slam. And we give a fat fee, is that fair? Yeah. To the surgeon, the guy, the guys and girls doing the work. As anesthesiologist, I'm paid for my time. It's time and materials. The beauty of that is that when I email Chris Paskowski or any of the other surgeons that work at our facility and I say, hey, I've got a patient from Wisconsin or Alaska or Texas that needs whatever, they're on it. I mean, that patient goes to the head of the class, and so the patient feels it. I mean, the patient gets a call from the surgeon and they feel that red carpet sort of thing. So that's how we came up with our pricing. And then our partnership agreement works like a law firm. So since we do not accept federal money, we can actually operate like a business. So we distribute profits based essentially like a law firm does.
So we have time for 2 more brief questions.
Let me just, Keith lowered the price of tonsillectomy from $3,600 to $3,100, all inclusive. And I saw that and he put it on his blog and I was like, Keith, would you talk to us the next time you do that? And he said, oh, don't worry, we took it out of the surgery center's, the facility fee. I was like, oh, well, never mind.
Dennis Rivero, Orthopedics, Oklahoma, Muskogee, Oklahoma. One of my concerns as a patient, and fortunately I've been in fairly good health throughout my life, but is catastrophic events. And when you talk about self-funding, that's great if people just need a scope here and a this and a that, but if you finally have one of your employees has some catastrophic event, I mean, that can really, I would think, cause great problems. And personally, I would be more than happy to just have some kind of catastrophic plan and pay everybody in cash. My question really is, like, how do you handle or worry about, the possible catastrophic events when you're self-funded? Sure.
Yeah, this is probably my bad. I was a little lazy with my lexicon. Anytime I say the word self-funding, the vast majority of the time you should hear partial self-funding, because almost every single one of my clients, with only one exception, buys a very comprehensive reinsurance policy that has various levels of risk retention for the employer. Smaller employers will maybe have a $30,000 per patient deductible, while a large employer, our largest group, has $250,000 worth of retention before the reinsurance carrier kicks in. And so that is how the risk is mitigated for the self-funded employer.
Okay, this is a really quick question. What's your count of how many other centers and facilities you've inspired so far?
Well, I'm aware of, as a facilitator, right over 50. Now there are more, but it's growing, and actually soon on the FMMA.org website we will hopefully have a very comprehensive listing of all of them that we are aware of. And most of them have been inspired by Dr. Smith.
Final question.
Up in Wisconsin, a patient who had a hysterectomy got a surcharge of $65,000 for robotic surgery. And I was wondering if you have robotic surgery and if you have a surcharge for that.
Oh, this is fun. So I do not have a robot, but our website has enough penetrance that we get requests for robotic hysterectomies, or somebody will come in that wants a hysterectomy, but their uterus is the size of a medicine ball and they've got to have a robotic procedure. So I don't have a robot. So I contacted a hospital in town that had a robot that's underutilized and said, will you give me prices for a robotic hysterectomy? And they thought about it for a minute and said, sure. So I said, well, this is great pricing. you need to put this out where everybody could see it, because I'm being asked, for all these procedures. And they said, no, our lawyers have told us that we can't post prices because it will conflict with contracts that we have with the federal government and other carriers. So I put their prices on my website. And so when you go through our website, if you're inclined, you will find procedure pricing there, not just for Deaconess Hospital, but for other facilities in this area that are not my facility. And I post their prices. And the hospital said, well, that's great. Can you collect the money and select the surgeon and pay everyone too? And I said, absolutely. So, my company that does that is inspired by Ayn Rand, is Atlas Billing, and so, they, I get a check, or we get the cashier's check or whatever. I select the surgeon to go to that facility. Otherwise, the hospital administrator would have a mutiny on his hands by selecting surgeons for this stuff. And I've got great pricing. I think a robotic hysterectomy is $12,350 all in. Everything, facility, surgeon, anesthesia, pathology, and the surgeon gets, I want to say he gets 2.5 times what Blue Cross would pay him to do it from Atlas.
Kind of in that same vein, a model that I'm very intrigued about, and I've actually heard it from a couple of different independent surgical groups. I just haven't seen them follow through with it yet, but I love the model. That would be an independent surgical group that decides that they are going to have bundled cash pricing. But just like Dr. Smith said, they would then go out and negotiate facilities and anesthesia on their own, but they would be seen as the seller. And my goodness, that's a powerful model.
That's awesome.
That is awesome. You don't happen to, are you in Oklahoma or Texas?
Oh. Well, that's close, right?
Well, and there's no reason why we can't go outside of Oklahoma and Texas. So we would love to talk to you if you have some employers in your area, because we travel a little bit. We've been to Pennsylvania a couple of times, even though we have no business up there, but hope springs eternal.
So I'd like to thank all three panelists today. Very informative presentations. Thank you. Now we'll call upon our AAPS president, Dr. Melinda Woofter, to do the meeting wrap-up. And don't forget to turn in your CME tracking form and your evaluation form at the registration desk out front in order to get your CME certificate.
Well, I think the time went quickly. I think we had a very strong meeting with the scientific content, learned about vitamin D, even how to treat iguanas, chemo brain, and actually I learned the HBO therapy can help aid those patients as well. And we all suspected the statins were poison, but that's been solidified for us. I trust many of you have made new acquaintances and new friends and had reunions with existing friends, and most importantly, networking. It's important to understand and learn from the leaders here that there are many other options, and you're not alone, and we have many resources for you. I'd like to challenge you all to speak to your fellow colleagues, tell them about AAPS, and do some recruiting so we can increase membership. But also your patients, educating them on what is going on. And I had an excellent suggestion. The movie that aired last night, those of you who saw it, it was quite frightening. And a suggestion was made that purchasing some of those movies yourself, taking them to your local parishes, maybe showing those people and parishes the what is going on, because they're going to be a key number of voters in this election. And I think people are asleep and they don't really understand what is going on. So at this time, I'd like to ask the new attendees how you've heard about AAPS, and perhaps what prompted you to come to our meeting. And we can pass the mic around. Are there any new attendees, first-time attendees? Bueller, nobody? No one? Oh, we have one over here.
I'm a new attendee. I came to the meeting. I'm an orthopedic surgeon out in southern Utah. And I came really at the invitation of my son, who's anesthesia fourth-year resident. And I thought this would be fun to rendezvous with my son at a meeting, even though I don't have really any interest. And I came away with a lot of good ideas, a lot of new connections. I look forward to joining AAPS. And I think it's a great organization. I'm concerned that it's not better known. And it makes me wonder why I see a lot of gray hairs like myself and just a few young people, and I worry about that as well, because I think it's a very well thought out organization that has a very necessary place in the medical community. So I'd say I have that concern. I'd love to hear that addressed, but I do plan to join the organization.
My name is Jason Bailey, and I'm a plastic surgeon in Houston, Texas, and a local colleague that's a dermatologist, Keith Schultz, who's not here, I believe, but told me about the organization, and I'm just building out my own surgical suite and had interest in the program and what was presented today, and I've been enlightened, and I appreciate y'all's group.
Thank you for coming. Appreciate having you here.
Hi, I'm Eva Stewart, pediatrician in Garland, Texas, and this is my first meeting. I learned about AAPS from my daughter, who is fourth year of in medical school in El Paso, Texas, and we were talking, and she learned it from actually a psychiatrist, because she was doing a rotation. So the psychiatrist said, well, you know, the better way, because I think they were talking about my frustration practicing pediatrics. And I went on the website immediately, and I said, wow, finally somebody can understand me, because I feel like I am in the zoo and I'm just this crazy doctor that talks about freedom and teaches my patient actually couldn't work for anybody else, because I do politically incorrect things like teaching my patient about freedoms and choices, and how, you know, their ground is being pulled from underneath them, really. And all of us physicians, basically. So I appreciate Association of Pediatrics. I'm from Poland originally, so I really understand communism and socialism, because my family suffered under the system for many, many years. My father was never a member of the party. He was a prominent scientist in Polytechnical Institute of Łódź. He was awarded awards from Humboldt Foundation when he did research to try to purify air and, you know, basically something to do with air pollution control. He has patents. The government actually, I guess, mandated that the production will be started and they could make money selling the inventions that my dad did, and it was never done. So anyway, that's how it all works, but he did start producing it in his own garage, and my sister took over the business, and they have my dad's products all over the world now. So that's my story.
My name is Dennis Rivero, and I've been a member for quite some time, but this is my first meeting. And like one of the other new attendees, I'm surprised that not more people know about this organization. And I'm very much in favor of the autonomy of the patient-physician relationship, and a great admirer of Dr. Orient. But I will say this, and I hope it's not taken the wrong way. I am not a liberal, but I am probably more libertarian in my views, and it's in keeping with the concept of freedom. And I think sometimes an organization needs to be a little bit more open, and I suspect a lot of people see this organization as being somewhat too right-wing. And it's probably flawed, that idea, but I would definitely like to see more people belong to this organization, because as I wrote to the board of directors of the AMA at one time, Dr. Orient has more testosterone in her veins than their entire staff.
Anyone else? No? Okay, one last segment. I'd like to open the mic for the good of the order. So if you have any comments, suggestions, or something you would like to share.
I don't know everybody, but I'd like to take just a second or two to remember some of our departed colleagues, Claude Boyd and Jim Pendleton, Howard Long, George Watson, Hilton Terrell. There are some that I did not know that I know some other people know. Nino Camardes. These were beloved long-term members of our organization, of our association, and think of them often and miss them. Thank you.
Hi, I'm Chandrasekhar Doniparthi, anesthesiologist out of Yuma, Arizona. I just want to bring up a point that I had with MOC in our hospital, and that was we were able to get rid of MOC at the medical staff level without much of a fanfare. There was an oncologist who did not want to recertify, and we had the dilemma in our medical executive committee. And they were discussing this, and I asked, is there any data that's showing that they're aware of that supports maintenance of certification? And they were all stymied, they did not know, and with the help of Jeremy, I was able to provide them with the information that they needed to make the decision themselves, and they did fall into saying, okay, maintenance of certification is not required for the hospital privileges. And that was a victory for AAPS, in my view, because without AAPS, I would not have known this information to pass it on. The second thing was about the interstate compact. The hospital administration came with the view that it was a good thing, and they were about to endorse it, and I had to say, stop. You have not known about the compact. You're only listening to what they want you to hear, but it can erode the individual physician's due process, and you had to inform our physicians who are coming into our facility about the process of getting licensure. They have an alternative that they should use, and this was not known. If it was not for AAPS and the information it provided, I could not have given that to our facility.
Yeah, Ken Christman and I yesterday called into the Interstate Medical Licensure Commission to voice the official views of the AAPS. That was my job to do, and because we had the call-in number, Chris could call in on his phone, and Ken Christman could call in on his phone and also contribute to that. I guess on October 3rd, there's going to be another meeting. If you go home and tell your friends to write letters to the commission and explain to them how bad their program is, I think we have a position paper online. You can take information from that. But essentially, the Nursing Interstate Compact requires one license for 25 states, nominal fee. This commission wants you to buy a license in every freaking state at full price plus, and a concept like that is going to die on the vine, as impression. But we need to say, I said to them, I would like to see you succeed, but with something reasonable, like the Nursing Compact. Please go and review that. And I talked about the other points that are delineated on file. Please go to the website, look at that document, and take the time to write a letter and complain to the commission, because they're trying to do the work of the FSMB, and I don't think they know that they're doing that.
Andy has a comment.
Just a humorous anecdote in response to the comment about our political perspective. Last year in St. Louis, we had a new attendee who came who was sent by his attorney. And this physician had had numerous run-ins with the medical board, and apparently his attorney said, you need to go to the AAPS annual meeting and some things there. So he came into our meeting completely blind about what we stand for, what we talk about. It was obvious he was from the left side of the political spectrum. And I chatted with him from time to time, and about the middle of the meeting, he came up to me and it said, you people scare me. And yet, by the end of the meeting, he was very grateful and continued to call me after the meeting was over. So maybe we opened some minds.
Any other comments? Well, my last duty would be to hand the gavel over to our next president, Michael Robb, who will do an excellent job for the organization. He's very active in Arizona already and demonstrates his leadership roles strongly. So, Michael.
There it is. Thank you so much, Dr. Woofter. This gavel is rosewood, glossed rosewood, and it says President, Association of American Physicians and Surgeons, AAPS, established 1943, and the sound block has an engraving of our motto, Omnia Pro Grotto, all for the patient. I would like to read 5 lines of inspirational thoughts written and spoken by Saint Teresa of Calcutta, who was canonized September 4th, 2016. And as you recall, she won the Nobel Peace Prize in 1979. Many of the physicians speaking today, in particular Dr. Rutgard, are living examples of these inspiring words. I'd like for you to reflect, please, on this and apply it in your own practice so that you can continue to thrive and survive. The fruit of silence is prayer. The fruit of prayer is faith. The fruit of faith is love. The fruit of love is service. The fruit of service is peace. So is there any motion on the floor to adjourn? All right then. Well, meeting is adjourned. Our next meeting, October 5th through 7th, Tucson, Arizona. Please be there.
I think they're going to have to adjust it afterwards. I did, but I think it's going to take them a couple days to, yes. Yeah, yes, yeah, it's just going to take, it's going to take a couple days for them to, thank you. Tucson, Arizona, as a DoubleTree by Reed Park. Yep, all right, sounds good. Thank you, Dr. Reagan. Thank you. Yeah, Dr. Just a quick reminder, if you're on the Surgery Center of Oklahoma tour, be in the lobby at 1:30. Thank you.